So our third speaker I invited is actually this is Dr. Eugene Richardson. He is assistant professor of global health and social medicine at the Harvard Medical School and assistant professor of medicine in the Division of Global Health Equity at the Brigham and Women's Hospital. And we actually interacted on a panel, and I really thought that his area of expertise is very unique as it really gets into the social justice and the impact of some of these emerging diseases and how climate affects certain populations disproportionately. So he received his MD from Cornell and then was at Stanford for many years to get his PhD in anthropology and then his internal medicine residency and fellowship training in ID and geographic medicine. He was previously the clinical lead for Partners in Health Ebola Response in Sierra Leone, and he continues to do work there, both looking at conducting research on social epidemiology of Ebola virus and COVID-19. He's also worked with the WHO on their Ebola work in the Democratic Republic of Congo. He has been also doing work on the COVID-19 response in Africa with the CDC. And his overall focus is on biosocial approaches to epidemic disease prevention, containment, and treatment, as well as the health effects of climate change. As part of these efforts, he's the co-chair of the Lancet Commission on Reparations and Redistributive Justice and a co-chair of the Global Environmental Change Commission on Climate Reparations. So I think this is a really, we're so happy you could be with us remotely. I hope your slides will work well, and if not, we'll get them to work somehow. But please take it away. And I asked him to give a specific example of how environment can impact a health issue, and he's going to talk about flooding in Pakistan and then bring that into his area of expertise. Thank you.
All right, thanks so much. It's a delight and an honor to join this distinguished panel today. Sorry I couldn't join you in person, but I will be, yes, talking about the flooding in Pakistan, disease outbreaks, and climate justice. And if any of you want to interact in the Twitter sphere, there's my handle. So I have no financial relationships with commercial entities to disclose. So I wanted to start out, it's not a real shameless plug, mild shame, of a book I wrote called Epidemic Illusions on the Coloniality of Global Public Health. Because I essentially study colonial and neo-colonial determinants of epidemic disease. And in this book, I basically explore how a lot of what we do in global health as far as humanitarian response and even the global health science actually perpetuates and reproduces some of the inequities we're trying to solve. And I, explore various routes, how this happens, various mechanisms based on my experience, mostly working in sub-Saharan Africa. And I describe coloniality, it was developed by South American scholars, notably Aníbal Quijano, as a matrix of power relations that persistently manifest despite a former colony's achievement of nationhood, attempts to capture racial, political, economic, social, epistemological, linguistic, and gendered hierarchical orders imposed by European colonialism that transcended independence movements and continues to oppress in accordance with the needs of capital accumulation, or as our first speaker was talking about, resource extraction. You can think of this as racial capitalism is also a different way of describing the same matrix of power relations. Kwame Nkrumah 60 years ago called it neocolonialism, and that really captures the dynamic that I study. He once said that, beware of the aid industry, because really what it does is gives a little with one hand to mask the huge amount of extraction that's going on with the other hand. And if you don't believe there is such a thing as neocolonialism these days, I often show a slide from 2017 that shows in the year prior, $160 billion was transferred to the continent of Africa in the form of aid, loans, and remittances. $200 billion came out in illicit financial flows. So continued illegal theft of resources from trade misinvoicing, tax evasion, and resource theft. So not even counting, repatriation of profits, there is still a legal amount or an illegal theft of resources that dwarfs anything we give as far as aid or development. So I actually don't think, I do think the word development is a farce. The only thing it could possibly mean is that the global South continues to develop us. And that understanding has relevance for understanding climate change and the health effects of it. So I like to think of, contributions from as far as carbon output to the atmosphere from the global North countries as a further form of colonization. In this instance, atmospheric colonization. Jason Hickel has a good paper in the Lancet Planetary Health that talks about this phenomenon of overshooting and undershooting. And what he did was to look at, per capita since the Industrial Revolution, what each country might have as a carbon budget to meet the 350 ppm boundary that we passed, 30 years ago. And so the US, for instance, the world total allocated budget would be 830 gigatons. Everything above that would be overshoot. So the US had 40 gigatons as part of their carbon budget, and our cumulative emissions. Now this is per capita emissions, but also takes into consideration consumption. So you might often see emissions reports that say, China is one of the biggest emitters. And you don't see China on this list because although they actually physically produce the most carbon emissions per year, if you look at where the products are consumed, so say a factory is making some sort of industrial tool, and that's all bought up by the US, then the majority of that carbon emission goes to the US because we're the ones consuming the product. And if you look at it that way, China is actually an undershooter. So we have the US, which has emitted almost 400 gigatons. We've overshot our safe carbon boundary by 40%. Next is Russia, Germany, UK, and on down. If you look at the undershooters, we have India at the top. So this 34% means they've undershot their carbon budget by 34%. They still have a huge amount of carbon budget to essentially contribute to industrialize. China still has 11% when you look at this per capita consumption model. And today I'll be talking about Pakistan because the recent floods were talked about by the UN Director General as the biggest climate catastrophe that he's witnessed. And even Pakistan is an undershooter. So they've contributed negligibly, or they still have a negative contribution essentially to carbon emissions, yet are facing the effects of it first and worst. So the floods last year started with the monsoons, June, July, August, and then resulting flooding that affected over 33 million people there, destroyed 1.7 million homes, nearly 1,500 people lost their lives, damages exceeded $30 billion, around 6,700 kilometers of road, 269 bridges, 1,460 health facilities were destroyed, almost 19,000 schools damaged, approximately 750,000 livestock killed, and around 18,000 square kilometers of cropland ruined. Not only 45% of their cotton crop, which is one of the key exports, but also their rice crop. So here we run into food insecurity because of the climate crisis that is compounded by grain exports coming from Ukraine being stopped. So there's also geopolitical considerations. So one thing that's new over the past 10 years on the climate science front is this attribution science. And to me, this plays a very important role in understanding, the contribution of anthropogenic emissions to the climate crisis. So right now, you couldn't say that anthropogenic climate change caused those floods full stop. What you can do is use attribution science, which can be thought of as, again, not being able to determine the cause of an event. But if climate change made some extreme events more likely to occur or more severe, then you could quantify by how much. And so World Weather Attribution is a group that does these studies, and they found that these intense rains were 75% more intense than they likely would have been if the climate had not warmed 1.2 degrees since the start of the Industrial Revolution. Here we have the UN General Secretary saying, "I've seen many humanitarian crises in the world, but have never seen climate carnage on this scale." And so here we see physical infrastructure collapsing on account of the flooding. We see houses underwater. And this to me was an interesting thing, not having been, I don't think I've worked in floods before as far as my humanitarian responses. So I'm used to having the white Land Cruiser to take me where I go. But it was so bad that this is what humanitarian relief looked like. People trains, carrying goods from place to place. So what are some of the epidemic ramifications of the flooding? They increase the breeding grounds for different types of mosquitoes. So for Anopheles, this leads to increase in malaria cases. And just in the 60 districts supported by the Global Fund, where I had access to WHO data, there were 4 times the more cases of malaria as in the previous year. And you see this standing water, right? That's the culprit. You have countries like Singapore that control a lot of arboviral and disease and malaria well, because they'll fine you if you have a bucket or a tire in your yard that can actually collect standing water, because that provides extra breeding ground for mosquitoes. Well, floods, there's no way of avoiding these pools that are left over that increase mosquito populations. That also leads to increases in dengue. And Aedes are the primary vector for dengue. So here you can see the monsoons in August lead to flooding and an increase in dengue cases. And the clinical pearl for dengue, as most of you know, is that it's usually the infection with the second serotype that causes the severe infection, presumptively through an antibody-dependent enhancement mechanism. But there's 4 serotypes. You get nailed with the second serotype, and that's when more of the hemorrhagic manifestations show. So here we see increase in cases based on flooding. Here's an interesting one. So you would expect the acute watery diarrhea cases to increase. And here in Sindh province, you see that they double by August and September. There was a lot of worry that cholera would too, but it didn't. So here we have cholera cases earlier in the year, and those kind of faced off. So it's complex. It's hard to predict which of the diseases that are theoretically possible, cholera being one of them, with all this standing pool of people having decreased access to sanitation, having to drink flood water, being removed from healthcare facilities, what effects these would have. But here's some of the data on diarrheal disease. And then lastly, if we're talking about syndemic contributions, malnutrition increased, such that more than 1 in 9 children under 5 admitted to health facilities were found to be suffering from severe acute malnutrition, which is, in these situations is often diagnosed by these upper arm circumference bands. And so that compounds, the effects of disease. So it's not just more people are getting infected, but higher percentage of people, especially children, are going to die because of concomitant malnutrition. And my mentor, Paul Farmer, who we lost last year, he always reminded us to, remember the treatment component and not just the infection rate component. Because in a place like this, you don't only see more cases, but when the floods prevent people from accessing healthcare facilities, then you have structural mechanisms which affect mortality rates as well. So it's not just incidence that goes up, but mortality. And we have to be attuned to those things. So I think I'll finish off by talking about maybe a different approach to climate vulnerability than One Health may get at. When I first went to undergrad and learned about biology and all of that, my understanding was that there are the biological mechanisms for people getting sick. So a sandfly is the vector for leishmania. It bites a person, and they get sick. Or the mosquito is a vector for malaria, bites a person, they get sick. And then you can trace how the parasite works and how drugs work. But I think I read Paul's book, Infections and Inequalities, for the first time back in 2002, where he lays out how socio-historical determinants get into people's bodies to make them sick. And I thought, wow, this was not part of my curriculum, but it was really transformative to me to look at how neocolonial forces add to making people sick. And so the story for Pakistan would be that they are a post-colonial nation, but prior to independence, working on this coloniality theory, the economist Utsa Panaik totaled or calculated that Britain drained $45 trillion from South Asia from 1765 to 1938. So if you look at the population that's in Pakistan after partition, that would amount to nearly $6 trillion siphoned. And the question to me is, do you think that there would be these issues as far as the damage from flooding if that $6 trillion were paid back in reparations? This is the kind of work we're doing on this Lancet Commission for reparations. We have 12 groups around the world that are totaling up the amounts owed for atrocities committed over centuries. And although we don't have a group on Pakistan, we do have one for India that's looking at intercaste reparations. We also have a group working on reparations for descendants of people enslaved in the US. And their goal would be to eradicate the wealth gap between Black and white people that is also can be seen as a legacy of slavery and Jim Crow and redlining and all these things. And the wealth gap is currently $10 to $12 trillion. And again, the question is raised, do you think if that 10 to 12 trillion were paid as reparations, that you would see the numbers that were shown for monkeypox in the last presentation? You wouldn't. And so I've arrived as someone who studies infectious diseases at, wanting to go as far upstream as possible. And I think all these roads end up in reparative approaches. Just as a quick side example of then what this kind of work leads to, we did a modeling study of what COVID would have looked like in the US had reparations been paid to Black American descendants of persons enslaved in the US. Basically found that there would have been 30 to 60% less transmission across the country just by intervening in the highest risk group or one of the highest risk groups and decreasing overcrowded housing and the ability to social distance. And this contribution really got into CNN and basically has earned us lots of hate mail and threats. Coming back to climate change, what can we do as physicians and researchers, to affect beyond just, providing treatment and, better epidemiological understandings of climate sensitive diseases? I think we have to get involved in the advocacy realm. And so as part of the reason we formed this Global Environmental Change Commission on Climate Justice. But then here's me at, this is at COP in Egypt. And instead of going to, a lot of the meetings, I was out joining debt justice groups for protests, talking about how debt cancellation and reparative approaches are important to solving some of the health issues that we will certainly see if status quo continues. I'll finish with an article from Senator Sherry Rahman, who is the climate change minister for Pakistan, and she sums it up quite well. Why should we in Pakistan pay for catastrophic floods we had? I want to say no part in causing, right? If we use the attribution science, we would say that those floods were 75% more likely, but it raises the point of current status quo approach to their $30 billion damage would be to take loans out from England or from Britain and the US and think about how sinister it is to have to take loans and pay interest from the person that caused your colonial or caused your vulnerability by siphoning your wealth over colonialism, but that also overshot to cause the more likely flooding phenomena. So if you see things this way, then I think your approach, again, as a researcher or climate change scientist, should be to try to get your foot into some of the advocacy realms for reparative approaches, because I don't see any other way of solving or not seeing a worsening of these phenomena without reparative approaches. And with that, I'll end, say thank you. And we have some time for discussion.
Thank you so much for that perspective. I think, when we look at all these intersecting Venn diagrams of what can cause disease and severity of disease, I think this is just another whole layer that we're all just starting to appreciate. And I think the younger generation is really attuned to this. I know a lot of our fellows are very interested in climate change and the disparities that occur, as a result of climate change. So I think there's even more areas that young people that are getting involved in research can, no matter what their interests or expertise, to address the bigger issue of infectious diseases. Are there any questions from the audience? Okay. Well, thank you so much for joining us.